Hello, dear friends. In our series of applied neuroanatomy, today we are going to discuss the anatomy of one of the most important regions in the skull base, and it has a complex anatomy. But actually, we did talk about this region when we were talking about the carotid artery, about the cranial nerves 3, 4, and 6, about the trigeminal. So this lecture will clarify all what is bit vague or complex in this region. First of all, the cavernous sinus is located in the middle fossa, as you all know, on either side of the sella turcica and sphenoid bone. It is present between an endosteal layer, the medial wall, and the floor, and meningeal layers of dura. So it is a space between the meninges and the endosteum. And it extends from the apex of the orbit to the apex of the petrous bone. So on either side, middle fossa, either side of the sphenoid sinus and sella, extending from the petrous apex to the orbital apex. The roof and lateral wall are made of two layers of dura, as we'll see now. The floor and the medial wall are made of a single layer of endosteum. It is the only place in the body where an artery, a very important artery, the internal carotid, passes in a venous structure. This is a view to show you the cavernous sinus in the middle fossa on either side of the sella and its connections. Of course, there is intercavernous connections, called the circular sinus between the two cavernous sinuses. It receives some veins and sinuses and drains into others. This is a coronal section showing the cavernous sinus, and you can see here it is present lateral to the sphenoid sinus and the sella, and it has got a roof, as we said, made of meningeal layers of two layers of dura. The lateral wall also is made of meningeal layers of dura, but the floor and the medial wall are made of a single layer of endosteum. So the cavernous sinus is separated from the sphenoid by endosteum, single layer, and is separated from the sella turcica, the pituitary, by a single layer of endosteum. This is to show you the structures present in the lateral wall of the cavernous sinus, or the structures present inside the cavernous sinus. Inside the cavernous sinus, we have the internal carotid artery. Then below and lateral to it is the abducent nerve. In the lateral wall, embedded in the inner layer of the lateral wall, as you will see now, we have nerves: the oculomotor nerve, the trochlear nerve, the ophthalmic division of the trigeminal, what we call V1, and the maxillary division is present in the floor of the cavernous sinus. The dural folds of the cavernous sinus, as we said, the lateral wall of the cavernous sinus is made of two dural layers, one thick outer layer following the contour of the middle fossa of the temporal dura, and a thinner inner layer of dura, which forms the wall of the superior orbital fissure, as we'll see now. And the two layers of the lateral wall of the cavernous sinus form the lateral wall of the Meccals cave also, and they are actually the upper and lower layers of the tentorium. So the upper and lower layers of the tentorium, when they proceed anteriorly, they change their direction from being horizontally oriented into vertically oriented, oblique first for the Meccals cave, then vertical for the lateral wall of the cavernous sinus. And the cranial nerves in the lateral wall of the cavernous sinus are not between these two layers, but embedded in the inner reticular layer. This is very important. Many people and many books till now say that the cranial nerve 3, 4, ophthalmic division of 5, V1, are present between the two layers of the lateral wall. No. Actually, it is embedded deep to the deep layer of the lateral wall, in between the two layers of the lateral wall of the cavernous sinus, there is nothing. And the two layers are separated anteriorly by the anterior clinoid process, with the inner layer forming the proximal ring and the outer thick layer forming the distal ring. The space between the two rings is called the clinoidal space, and it contains the clinoidal part of the carotid extracranially, with the optic nerve above and the third nerve in the superior orbital fissure below. So let's see it now. This is the cavernous sinus. This is the middle fossa. This is the outer layer of dura. This is a proper dura. And this dura, if you peel it, you find another thinner layer of dura, and the cranial nerves are embedded deep to this layer. This outer layer of dura follows the dura of the temporal fossa, follows the contour of the temporal lobe, and the second layer of dura, the deep layer, forms the superior orbital fissure. So this is a diagram. This is a very nice diagram showing that the cavernous sinus lateral wall is formed of two layers of dura. The outer layer, which is the dura propria, and inner reticular layer, and in between the two layers, the cranial nerves are not there. They are embedded deep in the deep layer. So if we remove the outer layer, you will not find the cranial nerves, you will find the deep layer of dura, and they are embedded in the medial surface of this deep layer of dura. This is very important. Here, the right cavernous sinus, the dura propria, and it is following the contour of the petrous bone and the temporal bone and the middle fossa. And here on the other side, when we removed these layers of the lateral wall, you will find the contents of the cavernous sinus, and you find a thin layer before reaching the nerves, which is the inner layer of dura. Here, talking about the right cavernous sinus, this is the right optic nerve, right carotid, oculomotor, and you look from lateral, from the middle fossa, and you find that there is a dura, proper dura here, and that Meccals cave is present posterior and below the cavernous sinus. You remove the outer layer of dura, you will find another layer of dura, a thinner layer of dura, through which the cranial nerves are apparent, which is the oculomotor, the trochlear, the V1, and the V2. If you remove this layer of dura partially, you will find that the nerves are embedded in this layer, and if you remove all the walls, you will find that the cranial nerves are more apparent. So, outer layer of the lateral wall cavernous sinus, dura, contour of the middle fossa and the temporal lobe. Removing the outer layer, you find a thin reticular layer. In between the two layers, the cranial nerves are not there. They are still deep to the deep layer. They are embedded in the deep layer of the cavernous sinus. This is a view of the cavernous sinus. Nice dissection. The left side, optic nerve, carotid, ophthalmic, and you find the two lateral walls of the cavernous sinus. This is the outer layer of dura, and this is the inner layer of dura, and you find the carotid here, the oculomotor, and V1. Here to show you that these two layers of dura forming the lateral wall of the cavernous sinus, when they reach the anterior clinoid, the outer layer becomes the upper part of the anterior clinoid, which is here the clinoidal space, and forms the distal ring. And the thinner inner layer continues as the superior orbital fissure and forms the proximal ring. So the proximal ring is the continuation of the inner reticular layer of dura. The distal ring is the continuation of the dura propria, where it is pierced by the internal carotid artery. Look here, when we remove the outer layer of dura, and you find here the oculomotor nerve, you find another thin layer of dura, not the nerves in between, but embedded in the other layer. And as we told you, the outer wall forms the distal ring, and the inner layer forms the proximal ring, and in between the anterior clinoid was existing here and removed, forming the clinoidal space. Again, this is the anterior clinoid in place, and this is the left side, left optic, left carotid. This is the oculomotor nerve, and this is the lateral wall of the cavernous sinus. This is the outer layer of dura, and this is the thin reticular layer of dura. Very obvious here. When you remove the outer layer, you don't find the cranial nerves immediately, but you will find another thin layer of dura where the nerves are embedded inside it. This is the dural folds, and to show you here also the blood supply apparent through, and the nerves are apparent through the inner reticular or inner thin layer of dura of the lateral wall of the cavernous sinus. Again, this is after removing all the layers. You will find the cranial nerves, oculomotor, trochlear, V1, V2, V3, Gasserian ganglion. Meccals cave. Meccals cave is an interdural space, as we said, posterior to the cavernous sinus and below it at the petrous apex. It is an interdural space having the same dural layers of the cavernous sinus, which are lateral double dural layers. As we said, one layer of dura propria and the other reticular layer, and it contains the Gasserian trigeminal ganglion, dividing into three divisions, the ophthalmic, maxillary, and mandibular divisions. So here you find that the cavernous sinus is here, posterior to it, and lower you'll find the Gasserian Meccals cave, Gasserian ganglion. The lateral wall of the Gasserian ganglion is the same dural layers of the lateral wall of the cavernous sinus, which is removed. And here we find the ophthalmic division of trigeminal V1, the maxillary division V2, and the mandibular V3. This is deep to the inner layer of dura. As we said, the same lateral wall of the cavernous sinus is formed of the same dural layers as the lateral wall of Meccals cave, the trigeminal root, Gasserian ganglion, cavernous sinus, outer layer is removed. See the Gasserian ganglion deep to the deep layer of dura. And this is after removing all the dural walls. You'll find here the V1, here the V2 through the foramen rotundum, and the V3 through the foramen ovale. Another view, Gasserian ganglion, ophthalmic division in the lateral wall of the cavernous sinus. This is Meccals cave, and this is V2 and V3. Contents of the cavernous sinus. The structures passing the cavernous sinus, as we said before, are the carotid artery, internal carotid artery, which is the most important structure inside the cavernous sinus, and the abducent nerve is lateral and inferior to it, and a carotid sympathetic plexus around the carotid, forming what we call the deep petrosal nerve. And the nerves passing through the lateral wall of the cavernous sinus are the oculomotor nerve from above downwards, trochlear nerve, ophthalmic division of the trigeminal V1, and the maxillary division of the trigeminal V2 in the floor of the cavernous sinus. So inside the sinus, carotid, artery, abducent, sympathetic plexus. In the lateral wall, oculomotor, trochlear, V1, and V2 in the floor. So here you will see a view of the right cavernous sinus, right optic nerve, right internal carotid artery, trinodal space, distal ring, proximal ring, oculomotor nerve in the lateral wall, the trochlear nerve in the lateral wall, V1 in the lateral wall, V2 in the floor, and inside the cavernous sinus, at a deeper plane, you find the internal carotid artery, which is here the medial loop, horizontal segment, and the anterior loop, and you find the abducent nerve below and lateral to the artery on its way to the superior orbital fissure. Another view, lateral view, internal carotid artery, the sixth nerve at the contents, oculomotor, trochlear, and should be here the ophthalmic division of the trigeminal, which is V1, going to the superior orbital fissure. It is cut here. So oculomotor, trochlear, ophthalmic division of the trigeminal in the lateral wall, V2 in the floor, and the internal carotid artery with the sixth nerve lateral to it. Coronal view, you'll find the carotid, the sixth nerve, and oculomotor, trochlear, V1 and V2 in the lateral wall of the cavernous sinus, embedded in the inner layer of the lateral wall. The cavernous carotid, as we said in the carotid artery before, extends from the petrolingual ligament to the proximal ring. It forms the medial loop, extends petrolingual, which is the proximal ring, extends petrolingual ligament of the proximal ring, and it forms the medial loop, which is convex posteriorly, the horizontal segment, and the anterior loop convex anteriorly. So in the cavernous sinus, we are concerned about the medial loop, horizontal segment, and anterior loop. It gives many branches: meningohypophyseal trunk from the medial loop, which is convex posteriorly, the artery of the inferior cavernous sinus, which is supplying the cranial nerves in the lateral wall of the cavernous sinus, and Meccals capsular artery, which is present in 30% of the cases, supplying the capsule of the pituitary. And the meningohypophyseal trunk further subdivides into the dorsal meningeal artery, supplying the meninges over the clivus, the tentorial artery of Bernasconi and Cassinari, or Davidoff and Schechter. These are the names of who discovered the branches, supplying the tent, and the inferior hypophyseal artery, which is branch also of the meningohypophyseal trunk, supplying the pituitary. So meningohypophyseal trunk, dorsal meningeal, tentorial artery, inferior hypophyseal artery. And the cavernous carotid is also surrounded by a sympathetic plexus, which is forming the deep petrosal nerve, which joins the abducent nerve, then leaves it again as the deep petrosal nerve, which unites with the greater superficial petrosal nerve, forming the Vedian nerve. Vedian nerve is supplying the mucosa of the nose and the sinuses, formed by a sympathetic part, which is the deep petrosal nerve, and the greater superficial petrosal nerve, which is a part of the facial nerve, the parasympathetic to the lacrimal gland for lacrimation. So here, these are the loops again of the internal carotid artery, the posterior loop in the petrous bone, the lateral loop, medial to the Gasserian ganglion, convex downwards and outwards. Then it goes upwards, the lateral segment, if you remember, on either side of the upper third of the clivus. Then the medial loop, which is convex posteriorly, horizontal segment, and the anterior loop convex anteriorly. Here is to show you the internal carotid artery going inside the cavernous sinus. Here is the lateral loop, medial to the Gasserian ganglion, convex downwards and outwards, then it forms the medial loop, which is convex posteriorly, horizontal segment, and anterior loop. If you see this, this should be the course of the internal carotid artery from the posterior loop, the lateral segment, which is medial to the Gasserian ganglion, forming after that the medial loop. And here you see the entrance of the internal carotid artery into the cavernous sinus through the medial lateral petrolingual ligaments or the sphenopetal ligaments or petrosphenoidal ligaments, medial and lateral, fixing the internal carotid in place. Then this is after the lateral loop. This is the medial loop, cavernous part here. This meningohypophyseal trunk coming out of it. This is the horizontal segment of the internal carotid, and this is the anterior loop forming giving the ophthalmic artery, and here is the clinoidal space, the proximal ring, and the distal ring. So this is the proximal, and this is the distal. This is the proximal distal, and this is the distal distal. We talked about this before. And these are the branches, artery of the inferior cavernous sinus, here. Here, another view, artery true view, anatomic view, artery of the inferior cavernous sinus supplying the oculomotor, the trochlear in the lateral wall, cavernous sinus. Meningohypophyseal trunk should be coming from here. And here, after piercing the rings, the carotid gives the ophthalmic artery. Branches, as we said, this is a posterior view, the left side, dorsum celli and clivus. You see the carotid, medial loop, giving the meningohypophyseal trunk, dividing into inferior hypophyseal, supplying the pituitary gland, and the superior hypophyseal comes from the carotid artery immediately after it leaves the distal ring, and it supplies the pituitary also. So this is the inferior hypophyseal trunk artery. We have the dorsal meningeal artery, which is supplying the dura over the dorsum celli and the clivus, dividing into medial and lateral branches. Medial branches anastomosing with the other medial branches. And we have the tentorial artery of Bernasconi and Casinari. So these are the branches from the medial loop, convex posteriorly, inferior hypophyseal, dorsal meningeal, tentorial artery. This is the artery of the inferior cavernous sinus, and you can see the Meccals capsular artery, which is not present in all the cases, but 30% of the cases. Again, meningohypophyseal trunk from the medial loop, tentorial artery, dorsal meningeal artery, and inferior hypophyseal artery. Artery of the inferior cavernous sinus and Meccals capsular artery from the upper surface. Artery of the inferior cavernous sinus from the lower surface, inferior surface of the carotid. So these are the intracavernous branches of the internal carotid, meningohypophyseal trunk, artery of the inferior cavernous sinus, Meccals capsular artery. Again, as we said, meningohypophyseal trunk, artery of inferior cavernous sinus, Meccals capsular artery, meningohypophyseal trunk supplying dorsal meningeal, tentorial artery, and the inferior hypophyseal artery. And you see here the superior hypophyseal artery arises from the carotid immediately after it leaves the distal ring. It is the only medial branch of the internal carotid. Cavernous cranial nerves, we talk about the oculomotor nerve. As we said before, present in the upper part of the lateral wall, passing from above downwards. So the interpeduncular fossa is at a higher level than the cavernous sinus, going to the superior orbital fissure, and the trochlear nerve extends from below upwards. Oculomotor from above downwards, trochlear from below upwards, lateral to the oculomotor nerve, passing also to the superior orbital fissure, and the V1 extending in the lateral wall of the cavernous sinus from the Gasserian ganglion, going also to the superior orbital fissure, and the maxillary nerve in the floor of the cavernous sinus. And last but not least, inside the cavernous sinus, abducent nerve in the cavity of the cavernous sinus arises from the pontomedullary junction, ascends upwards for a while in the basilar sinus, and then goes below the posterior petroclinoid ligament, Dorello's canal, lateral to the carotid and inferior to it, also passing through the superior orbital fissure. So these are the cranial nerves inside the cavity and in the lateral wall of the cavernous sinus. And if you have this view, this is the left side. You see the oculomotor nerve is coming from above downwards. You see here the Gasserian ganglion dividing into V1 and V2. You don't see here the trochlear nerve, but here, after removing the dural layers, intrapeduncular fossa going downwards to the superior orbital fissure is the oculomotor. The trochlear going from below upwards, crossing lateral and crossing the oculomotor nerve, so that the oculomotor nerve will go down in the superior orbital fissure in the oculomotor foramen, and the trochlear nerve crosses from below upwards, reaching the roof of the orbit, supraorbita, to supply the superior oblique, and which is the only muscle supplied from the upper surface, the outer surface. So this is the oculomotor, this is the trochlear, and V1 is also in the lateral wall of the cavernous sinus, embedded in the deep layer, going also to the superior orbital fissure. Here is the floor. We have the V2 and V3 going into the mandibular foramen. V2 is in the floor, V3 is outside the floor. Another view, more clear, intrapeduncular fossa, oculomotor nerve between the posterior cerebral and superior cerebellar, going through the oculomotor foramen or oculomotor trigone, and going inside the cavernous sinus, and the trochlear nerve from behind, passing edge of the tent in, also reaching the cavernous sinus in the lateral angle of the oculomotor trigone or oculomotor triangle. In the lateral angle is the trochlear nerve, and it is passing from below upwards, crossing the oculomotor nerve lateral to it, on its way to the superior orbital fissure. Very nice view, right side, right optic, this is the left optic, carotid, the lateral loop of the carotid convex downwards and laterally. This is the posterior loop in the petrous, this is the lateral loop, and then this is the lateral segment along the upper clivus, and then the medial loop, convex posteriorly, horizontal segment, and the anterior loop convex anteriorly. This is the clinoidal space. Cavernous sinus in the sphenoid sinus. Cavernous sinus is located, if you look from inside, this is very important in transsphenoidal surgery, you'll find that it is located on either side of the sphenoid sinus and the sphenoid bone, and the lateral segment of the carotid, which passes above the foramen lacerum, but not through it, is present on either side of the upper clivus, upper third of the clivus, to form the cavernous bulge on either side of the sella, forming and sharing the medial and lateral opticocarotid recesses with the optic nerve. So this is the view from the transsphenoidal approach, opening the sphenoid sinus. This is the sella turcica, this is the clivus, this is the dorsum celli. On either side of the upper third of the clivus, there is a part of the internal carotid lateral to it, hugging the upper third of the clivus, which is the lateral segment, on its way to form the enter the cavernous sinus, forming the medial loop, convex posterior horizontal segment, and then the anterior loop, and here the carotid with the optic nerve form what we call the opticocarotid recess. This is actually the lateral opticocarotid recess. If you go through it, you reach the anterior clinoid. And there is a smaller one, which is the medial opticocarotid recess. If you go through it, you reach the middle clinoid. What is the middle clinoid? It is the most lateral part of the tuberculum cell. And in between the medial and lateral opticocarotid recesses, this is the optic strut, where the clinoid is attached. So, again, sphenoid sinus, the sphenoid sinus, septum in the sphenoid sinus, the sella turcica, the carotid on either side of the clivus, then on either side of the sella turcica, and the opticocarotid recess. On the left side, opticocarotid recess, the lateral, and the medial opticocarotid recesses present here. A very nice view. The paraclival internal carotid, the lateral segment of the internal carotid, and then continues in the cavernous part. What is the cavernous part? The medial loop, horizontal segment, and anterior loop. A very nice view here to see that the lateral segment is present lateral to the clivus above the median nerve. So, at the root of the pterygoid, medial lateral pterygoid plates, there is a root, and this root, this is the medial and the lateral pterygoid plate, this is the root, and there is a nerve coming, is the median nerve, formed by the union of the deep petrosal nerve and the greater superficial petrosal nerve. Above this nerve, the carotid is lateral to the clivus. Below the 2/3, it is a bit lateral to the clivus, not immediately lateral to the clivus, a bit lateral to the clivus. Again, sella, clivus, lateral segment of the internal carotid, the medial loop, horizontal segment, anterior loop. Another view to show you what is the relation exactly. This is the sella turcica. This is clivus, carotids. This is the petrous carotid. This is clivus here, Look, the lower 2/3 of the clivus, the carotid is a bit lateral, but the upper third of the clivus, carotid is immediately lateral to the clivus, and then it enters here the cavernous sinus, cavernous segment. Here is the lateral segment. Here is the cavernous segment, lateral to the sphenoid bone, lateral to the pituitary gland. And these are the cranial nerves in the lateral wall of the cavernous sinus when seeing them from medially. Cavernous regions, triangles. Some people talk about the triangles, but don't panic, it's very easy, and you have to be ready to answer. And there are actually 10 triangles. Very, very easily you can remember them. 4 related to the cavernous sinus, 4 related to the middle fossa, that makes them 8, and 2 paraclival in the posterior fossa. So 4 cavernous sinus, 4 middle fossa, and 2 posterior fossa. The 4 cavernous sinus triangles are the anteromedial triangle of Dollens, Professor Vinko Dollens, Ljubljana, who rediscovered the cavernous sinus, and it's called also the clinoidal triangle. It is between the optic nerve, as we'll see, the oculomotor nerve, and the entrance of the oculomotor and optic nerve to the dura. So this is a very important triangle, anteromedial triangle. You see that we have 2 anteromedial triangles. Some people, Dollens, called it anteromedial, but you can call it clinoidal triangle. Second triangle, you all know about it before, is the anteromedial is between 2, 3, and the entrance of the dura of 2 and 3. Oculomotor triangle is very famous between the anterior and posterior petroclinoid ligament and the interclinoid ligament. You saw it before with the anatomy of the 10th tentorial hiatus, anatomy of the oculomotor. So this is the first one, this is the second one. Then the supratrochlear triangle, these are the cavernous sinus triangle, above the trochlear nerve, so it is between the trochlear and the oculomotor. And the infratrochlear is below the trochlear nerve, so it is between the third and fourth superiorly and V1 inferiorly, and is called Parkinson's triangle. Professor Dwight Parkinson discovered this in the 70s, and we said that this window we can enter the cavernous sinus between the oculomotor trochlear above and between the V1 ophthalmic division of the trigeminal below. So, 4 triangles related to the cavernous sinus: anteromedial, clinoidal, oculomotor, all know about, supratrochlear, infratrochlear. The 4 middle fossa triangle, the anteromedial triangle, another anteromedial triangle, yes. You can call it the other one clinoidal, and this is the anteromedial of Mullen, the other of Dollens. If you call it anteromedial triangle of Dollens, this is the anteromedial triangle of Mullen. Or you call the other one clinoidal, and this is the anteromedial triangle between V1 and V2. And a line between the superior orbital fissure and the foramen rotundum, as you will see. And the anterolateral triangle is lateral, of course, to the anteromedial triangle, is between V2 and V3, and a line from the foramen rotundum to oval. V2 in the rotundum, V3 in the oval, a line in between. And here also, V1 and V2, V1 is the superior orbital fissure, V2 in the rotundum, so it is between the superior orbital fissure and rotundum. The other 2 triangles are very, very, very famous in the middle fossa, which is the posteromedial triangle of Kawasi, because we have the Kawasi approach to the lateral pons. It is between the greater superficial petrosal nerve. It is medial to the greater superficial petrosal nerve. It is present on the petrous bone between the greater superficial petrosal nerve, the V3 and the superior petrosal sinus, and the posterolateral triangle of Glasscock's, where you can expose the carotid in the floor of the middle fossa, is between also lateral to the greater superficial petrosal nerve, between it, V3, and a line from the foramen spinosum to the arcuate eminence. So we have 4 triangles of the middle fossa: anteromedial, anterolateral triangle, anteromedial between V1, V2, anterolateral between V2, V3, Kawasi and Glasscock's triangle, medial and lateral to the greater superficial petrosal nerve. Now we have 8. We are left with 2. Posterior fossa, the paraclival triangles, is the infromedial triangle, is, as we'll see now, always remember the entrance of 4 and 6. So the entrance of 4, the trochlear, and the abducent with the posterior clinoid, they form the infromedial triangle, and the entrance of 4 and 6 and the petrosal vein where it enters the superior petrosal sinus forms the infralateral triangle. So because they are in posterior fossa, they are called inferior. They are paraclival. One of them is medial, 2, 4, and 6 with the posterior clinoid. One of them is lateral to the line between 4 and 6 with the entrance of the petrosal vein into the superior petrosal sinus. So let's see here, without studying too much. As we said, the triangles of the cavernous sinus, one of them is the clinoidal triangle, which is occupied by the clinoidal space, which is called the anteromedial triangle of Dollens, which will show us which is present between the proximal ring and the distal ring after removing the anterior clinoid, and the content is the extracranial carotid. It is part of the what we call the clinoidal carotid before it pierces the dura in the distal ring and enters the intracranial cavity. From the cavernous sinus to the clinoidal space, it's anteromedial triangle. And the other one, of course, you all know about it, oculomotor triangle, is between the posterior petroclinoid ligament, posterior petroclinoid ligament, between the petrous bone posterior clinoid, anterior petroclinoid ligament, between the petrous apex and the anterior clinoid, and the interclinoid ligament between the two clinoids. So, and of course the supratrochlear triangle above the trochlear nerve between the trochlear and oculomotor, and the infratrochlear below the trochlear nerve between oculomotor and trochlear and the V1, what we call the Parkinson's triangle. So these are the four triangles of the cavernous sinus. Again, clinoidal or anteromedial of Dollins, oculomotor triangle, supratrochlear triangle, and infratrochlear triangle or Parkinson's triangle. Again, in the middle fossa, these are the four of the cavernous sinus. Four of the middle fossa, V1 and V2, the anteromedial triangle, and the line from the supraorbital fissure to the foramen rotunda. So this is the triangle. The anterolateral triangle, V2, V3, and a line from the foramen rotundum and the foramen ovale. So these are two triangles of the middle fossa, and in here the other two triangles of the middle fossa, the posteromedial triangle, which is medial to the greater superficial petrosal nerve of Kawasi, and it is present in the petrous bone, and the posterolateral triangle of Glasscock's present in the floor of the middle fossa. As we said before, the greater superficial petrosal nerve is here. What is lateral to it is present in the floor of the middle fossa. This is the middle meningeal artery, foramen spinosum, behind it, but the Glasscock's triangle is present in the petrous bone, medial to the greater superficial petrosal, between the V3, between the greater superficial petrosal nerve, and between the petrosal sinus. So this is the Kawasi triangle, and when you remove this, the thin part of the petrous bone, you enter the lateral pons. And lateral to it is Glasscock's triangle in the middle fossa. So we have here four triangles and four triangles, 8 triangles. Another time, clinoidal triangle, the oculomotor enters the oculomotor triangle. The trochlear nerve, we have the supra and infratrochlear triangles. V1, V2, there is a triangle. V2, V3, there is another triangle. And posteriorly, Glasscock's and Kawasi. The paraclival triangle, also present in posterior fossa, called the inframedial, infralateral. But here we're talking about the oculomotor triangle. Of course, you all know about it. The anterior petroclinoid ligament, the posterior petroclinoid ligament, and the interclinoidal ligament. Oculomotor nerve enters through it to the cavernous sinus. Trochlear is lateral to it at the decussation of the free and attached borders of the tent. So the lateral angle of the triangle, trochlear. Central part, oculomotor. Again, what we can see here is to show you the Parkinson's triangle between the oculomotor and trochlear and V1, supratrochlear between oculomotor and the trochlear, and this is the middle fossa triangles, the anteromedial and Mullen and anterolateral triangle, and this is the Glasscock's triangle and Kawasi triangle. Again, you can see here the greater superficial petrosal nerve. Kawasi is here, Glasscock's is here, and the anteromedial triangle is here, the anterolateral triangle is here. Middle fossa triangles another time. Between V1 and V2, superior orbital fissure and foramen rotunda. Medial, anteromedial triangle of Mullen, anterolateral triangle between V2 and V3, rotundum and oval. This is a left side very nice view to explain what we want to say. This is the greater superficial petrosal nerve. This is lateral to it. Glasscock's triangle, as we said, it is in the floor of the middle fossa where you can expose the carotid if you need proximal control in cavernous surgery. And medial to the greater superficial petrosal nerve in the surface of the petrous bone is Kawasi triangle. So this is in the floor and this is the anterior petrous bone. This is lateral to the greater superficial petrosal nerve, and this is medial to the greater superficial petrosal nerve. This is the bone you can remove, thin bone. The cochlea is more lateral. So the cochlea is here, lateral to these two triangles, but here you find some bone and air deep to this bone, where you can remove this bone. You enter to the lateral pons, you enter to the anterolateral part of the pons. When you remove this bone in the middle fossa, you expose the internal carotid artery on its way to the cavernous sinus. So, Glasscock's, Kawasi. This is the cochlea, more lateral. Triangles, posteromedial triangle of Kawasi, posterolateral triangle of Glasscock's. Again, posteromedial triangle, the superficial petrosal nerve in the petrous bone, and the posterolateral triangle of Glasscock's is lateral to it. This is in the floor of the middle fossa. This is in the anterior wall of the petrous bone. You see it? Cochlea is more lateral. Again, greater superficial petrosal nerve. What is medial is here, between the nerve, between the V3, between the petrosal sinus, and what is lateral to it is between the greater superficial petrosal nerve, between V3 also and the arcuate eminence. So this is a triangle. This is another triangle. Paraclival triangles, posterior fossa, either side. Always remember where is the sixth nerve and 4, the trochlear and the abducent. A line drawn from the entrance of the abducent nerve to Dorello's canal and entrance of the trochlear nerve to the cavernous sinus. The line is here, and here what is medial to it is the infromedial triangle. What is lateral to it is the infralateral triangle. So one of the sides of the triangle, the line between 6 and 4. The third one is the third point for the medial is the posterior clinoid. And the third point for the lateral is the entrance of the petrosal vein into the superior petrosal vein into the petrosal sinus, superior petrosal sinus. So the inframedial triangle between abducent, trochlear, posterior clinoid. Infralateral triangle between abducent, trochlear, and the entrance of the petrous superior petrosal vein into superior petrosal sinus. This is to show you the medial with the posterior clinoid. This is a true view. Here is trigeminal, here is the sixth nerve. You'll find here the trochlear and the line between them and the posterior clinoid. You find the nerve. Venous connections of the cavernous sinus receives from the following veins. Of course, it is a very important sinus. It receives the ophthalmic veins draining the orbit, superior and inferior ophthalmic veins. It receives the sphenoparietal sinus on the free edge of the sphenoid ridge, and it received the superficial middle cerebral vein present in the sylvian fissure, and from below it receives the pterygoid venous plexus. So laterally, anteriorly it receives the ophthalmic veins, laterally it receives the sphenoparietal sinus, superiorly it receives superficial middle cerebral, and inferiorly it drains the pterygoid venous plexus, and it takes the blood from all these areas and distributes it to the superior petrosal sinus, to the junction of the transverse and sigmoid, inferior petrosal sinus to the jugular vein in the jugular foramen. And they are interconnected by intercavernous connections. So this is the right and left cavernous sinuses, intercavernous connections, receiving the ophthalmic veins and draining into the inferior petrosal to the jugular, superior petrosal junction of transverse with the sigmoid. More clear view. From anteriorly it receives from the ophthalmic veins, from lateral it receives the superior sphenoparietal sinus, from superiorly it receives superficial middle cerebral vein, from inferiorly it receives the pterygoid plexus, and it drains through the superior petrosal sinus to the transverse sigmoid junction and inferior petrosal sinus to the jugular vein, and they are interconnected by the anterior-posterior intercavernous connections. What we call the anterior intercavernous, posterior intercavernous sinus is the basilar. Clinical importance of the cavernous sinus. There is a site of cavernous sinus thrombosis, a common complication seen in those working in the field of neuroscience. And it is a site for many tumors that can be approached, like surgical like meningiomas, chondrosarcomas, schwannomas, and cavernomas. And gamma knife is a treatment of choice for cavernous sinus meningiomas. In the early 90s, we used to operate on many meningiomas, but if it is a secondary meningioma, it is coming from outside, reaching the cavernous sinus, we operate on it. Primary cavernous sinus meningiomas, now the gamma knife has the upper hand, but for other tumors, we can still approach it, and it is also the site carotid cavernous fistula. So cavernous sinus thrombosis, if you have an infection in the face, the dangerous triangle, if you remember from the general surgery, if you have an infection in the region of the nose, the medial surface of the orbits and the eyes, upper lip, it can reach the venous drainage, and infection makes a thrombus in the cavernous sinus that causes blindness, and it can reach the other cavernous sinus by intercavernous connections. This is a picture of bilateral cavernous sinus thrombosis, started the right side, extending into the left side, very serious complications of ophthalmoplegia and blindness. The second thing, of course, here we give anticoagulants and antibiotics. And the second thing is carotid cavernous fistula. We have 4 types of fistulas, A, B, C, and D. You shouldn't know all the details. A is the high flow, B, C, and D are low flow. The A is direct injury to the carotid, fracture base injury to the carotid, direct communication between the carotid and the cavernous sinus, high flow fistula. The B type is between the branches from this is the A. The B is from branches of the internal carotid, intercavernous branches, and the cavernous sinus, low flow. C is between branches from the external carotid and the cavernous sinus, like the middle meningeal and things like that. And D, combination between internal carotid branches, external carotid branches, and the cavernous sinus. So this is direct high flow. This is from the branches. B, internal carotid branches. C, external carotid branches. D, internal and external carotid branches. This is to show you how a type A fistula, there is an injury in the wall and the blood, the arterial blood, goes inside the cavities of the cavernous sinus, forming a very high flow venous drainage between the artery and the vein. Makes ophthalmoplegia, it makes congestion of the eye, you hear a bruit, and you find here that the internal carotid artery is injured and the cavernous sinus is arterialized, filled with arterial blood. And here, after the coiling, and you preserve the intercavernous carotid artery, and the fistula is closed with the coils. Another view. Here is the fistula, and here, after coiling. Approaches, we have the cranio-orbital zygomatic approach. We'll not talk about too much details. The Dolenz epidural approach, the subtemporal approach, the pterional approach, endoscopic transsphenoidal approach to the cavernous sinus. This is orbitocraniozygomatic approach. You remove the zygoma, you remove the zygomatic arch. For lesions high in the interpeduncular fossa or the cavernous sinus, and you do the pterional approach combined with the removal of the zygomatic bone, either a zygomatic bone only or zygomatic bone and zygomatic arch with it. So this will be the flap. You combine the zygomatic bone with zygomatic arch with the flap to reach the cavernous sinus. So removing this bone will give you a very nice view of the cavernous sinus. This is a coronal or anteroposterior view showing where we do the incisions to get the bone as one unit. This is the view as after removal of the zygomatic bone, zygomatic arch. You can look up. When you remove more down of the bone, you can look more up to the interpeduncular fossa. You can reach a basilar tip and aneurysm. And also the endoscopic, when you go from the inside to the cavernous sinus, as we said, it is lateral to the pituitary gland. Sometimes we can open the cavernous sinus and reach tumors, pituitary adenomas extending from the gland laterally through the endosteal layer, and I can take what is inferior to the internal carotid, what is medial to the internal carotid, but what is lateral is a bit difficult to reach. However, there is an approach called the transpterygoid, endoscopic transpterygoid approach to the cavernous sinus. You can reach as in the middle fossa as far lateral here. You can see the internal carotid artery. Here you can see the sixth nerve. Here you can see the third nerve in the lateral wall. So this is an approach medial to the carotid, and this is a more lateral approach to the cavernous sinus through the removal of the pterygoid bone. But this is to know that you can approach the cavernous sinus and can open the cavernous sinus from below. Thank you very much for your attention. I know that we talked too much about the cavernous sinus, but it was years ago, it was a taboo. And thanks to Professor Dollens in the late 80s, that we can re-explore again this sinus, we can re-operate again, and we have a better knowledge of the anatomy, as we told you before. And we hope to see you again very soon in one of the most important topics we're going to talk about. I think the next topic will be about the anatomy of the orbit. Thank you very much for your attention, and take care.